Welcome to another day in paradise. So today's my full schedule, back to the grind. I think I got between 17 and 18 patients. My name is Dr. Isang. I'm a cardiologist, showing you the day in the life of a cardiologist, non-invasive cardiologist. So my first patient is a brand new one, and it's coming in for atherosclerotic disease of the coronary arteries. Likely they had some type of either CT scan or a calcium score. Just popping up. Okay, they had a calcium score. Boom. Calcium score is elevated. So a calcium score just lets you know how much calcium you have around your arteries, which can be a precursor for plaque buildup, which can be a precursor for, something like a heart attack. So if you have an elevated calcium score, there are other questions we have to ask and see if they have high cholesterol, whether the cholesterol is under control, strong family history. If they're having symptoms, then a lot of times we may need to do a stress test to make sure that that plaque isn't restricting, or that calcium isn't restricting flow in the heart arteries. So he not been really having any symptoms, and my goal was to just treat him, medically, lifestyle changes, nutrition. But there was one thing that he said, and he said, my brother, my father, my grandfather, and my great-grandfather all had heart attacks. And with that, there's a concern that he may not have any symptoms, but he may also have a heart attack in the future. Because of that, we're going to plan for a stress test to make sure that the calcium isn't obstructing any flow. If it's not, then we'll continue with our plans with just lifestyle changes. If there is issues with the stress test, then we will do a heart catheterization to make sure that abnormal calcium, that abnormal stress test is not due to blockage, and potentially prevent a heart attack from happening. As above, we will plan for stress tests for further evaluation period. Now, the hard part was, do I just see them as they come, or do notes? And I feel like a lot of times when I see them as they come, I do my notes pretty late, so I decided to just finish my notes each one. It may make me about 2 to 3 minutes late, but I'll be more efficient. All right, so this next patient is coming in for follow-up with pacemaker and coronary diseases. Had previous bypass surgery. Overall, has been doing well. One of the biggest reasons that we see them every few months, every 6 months, is due to the pacemaker. I want to make sure the device is working appropriately, make sure that he doesn't have any questions, not having any issues. Lice device check, everything was doing well, so I anticipate he's going to be doing well, and we'll follow up in 6 months where we'll interrogate his device. And plans have changed a little bit. All my patients ended up just showing up all at once, so I'm still going to talk about them and any interesting cases that I've seen, but I'm not going to do my notes. Just going to try to see them as quickly as possible. I got about 3 or 4 more, but 5 or 6, 7 came in all at once, and now I'm getting palpitations. But this next one that I'm seeing is for coronary disease, aspired bypass. So last time I saw them was about 6-7 months ago, so that means they're doing well. I'm going to make sure that all their risk factors are still being treated appropriately. If it is, then we may even talk about potentially going to 6 to 9 months, even 9 to 12 months, just depending on how much autonomy they want in caring for themselves while I'm there to support them. All right, so the last patient that I just saw was for atrial fibrillation. So she has a form of atrial fibrillation known as permanent atrial fibrillation. So that means that, and we've exhausted all options to try to get her in normal rhythm, ablation, cardioversions, different antiarrhythmic rhythm controlling medications, but we've been unsuccessful. We checked her ultrasound of her heart squeezing appropriately, but more importantly, she's not having any symptoms, so we would try to keep her in rhythm without really having any real benefit from her lifestyle-wise. So we've all come to the conclusion that we're going to keep her in rhythm, in atrial fibrillation, out of rhythm, or we're going to be okay with her not being in rhythm. And she's actually been in here in this AFib for several years now, so she has permanent atrial fibrillation. We looked at lifestyle changes, weight loss, monitoring her weight. The most important thing when it comes to atrial fibrillation is making sure that you're not at risk of having a stroke. people who have increased risk. There's a mnemonic that we use called the CHAS-VAS score, but CHF, hypertension, age greater than 65 and 75, 2 points for 75. And diabetes, vascular disease, previous strokes, TIAs, chats, aortic plaque. So the more risk factors you have, the higher risk you have of having a stroke, and you need to be on blood thinners. And unfortunately, aspirin is not strong enough, so we typically have them to be on medications such as warfarin or Coumadin, Eliquis, or Apixaban, Xarelto, or Rivaroxaban, or Pradaxa. So currently on Eliquis, been doing well. Follow up, make sure not having any issues. Most important thing is going to be monitoring weights, because a lot of people can also have diastolic dysfunction and heart failure-like symptoms. So notice that the weight is starting to increase or change, or more shortness of breath, then those people need to be on a water pill or take an extra water pill during those days that they feel worse. She's doing well. Going to follow up in about 6 months. All right, so I'm about to start off with my afternoon patients. I was able to complete most of my notes. I think I have one more note to finish. My afternoon consists of about 8 new patients, with 2 of them being brand new. The first one that I'm seeing, well, brand new to me. This one is a transfer patient from another one of my colleagues that more likely has retired. Yes, from one of them that resigned. So this person has history of coronary disease, have had previous blockage, previous stents, mostly just making sure that they're doing well. So I'll be interested to see what they feel, how they feel, and if there's anything that needs to be done in regards to their lifestyle changes or risk factors of heart disease. As I expected, she is doing really, really well. Has been doing everything that we want her to do. She's a beast. She checks her weight every day. She notices when she is half a pound more than she should. So it's pretty awesome that she makes my job easy, because she knows what to do. The only thing that she asked for was for her refills. She's had recent stents, so a lot of times when someone has a stent, the guidelines want you to be on 2 blood thinners for at least a year, and afterwards we'll follow up and see whether we can drop one of your blood thinners. Most of the people, we do drop them. If there's someone who's had multiple stents or have multiple other risk factors, maybe they've had strokes, maybe they've had TIAs or mini strokes, maybe they have clots in your legs, we may want them to be on those 2 blood thinners lifelong. Or even if they have significant blockages, and let's say you had 4 blockages but you were only able to fix 3 of them, then there's a risk and benefits of being on blood thinners. Risk of bleeding, and the benefits is prevention of a repeat event. So for her, we're going to have a discussion in about 6 months about whether we want to continue dual antiplatelets or 2 therapies for her continue 2 blood thinners, or should we just go ahead and drop the 1? There's no wrong answer, there's no right answer. She wants it to be up to me, and the question is, do I want to treat her by the guidelines, or do I want to treat her how I would want it to be treated? Because, if it was let's just say this, if it was my dad, I would do both the blood thinners. If it was my mom, I would just use 1, because of the risk factors, because of the history. So the good thing is that I have time to go back and talk to her in about 6 months. The next patient that I'm seeing is a follow-up visit, but it's one of those where he wanted to see me ASAP or as soon as possible. So usually they've either been hospitalized or something else is going on. So I'm going to be checking the hospital records to make sure that I'm not missing anything that can help explain why he needed to see me urgently. I had just seen him recently too, so it just says ASAP. Okay. I just realized it looks like he has been having chest pain. Got it. All right, so he's here for a follow-up for chest pain, which is interesting. Okay. So there's plan for us to do an intervention on him, but he's still having pain on the 16th, so, okay. Just following up on symptoms and seeing how he's feeling. A lot of times if someone is having discomfort and they cannot wait for a certain procedure, we may need to see if we can get it done as soon as possible versus having it scheduled out. Unfortunately, with the holidays, it does happen a lot, and not just holidays, just this time period, more and more procedures are typically warranted or done to basically to try to get everything done as much as you can before the new year. So I ended up seeing more patients than I anticipated I was going to see. I ended up seeing 17 to 18 patients. Thankfully, tomorrow's a half day, so I'll see about 7 to 9 patients. And because of that, I'm going to finish up these notes, and then early tomorrow morning before I see my patients, I'm going to let you guys know some of the interesting cases that I saw, especially one that basically I told him today he was my doctor and I was his patient because he gave me really, really good advice about life. Can't wait to tell you. I cannot wait to talk to you guys about it. So I ended up seeing a lot of different patients yesterday for a lot of different things. I think I ended up seeing, like I said, between 16 and 18 patients. Of course, the most common things that I saw were things that were related to heart rhythm issues, but with cardiology, the bread and butter things that you see also includes coronary disease, so people that have had blockage in one way or another, and that blockage could be due to heart attack, or it could be due to us finding it before the heart attack and progressed, or the heart attack happened. So I saw a lot of different patients regarding that. So of course the most interesting ones are the ones that are you've fixed the issue, but then they're still having a lot of discomfort. So there was one specific patient that I saw for coronary disease, and he ended up having stents. Unfortunately, is still having a lot of discomfort. So one of the things that we have to realize that when we think about coronary disease, when we think about blockage, we always consider that it's due to the big arteries that are in the heart, the macrovascular arteries, when in reality there's a bigger supply of arteries too. There's a microvascular supply. So one of the things that we're going to try to treat him for is something called microvascular ischemia. So blockage in the smaller arteries that we can't see with a heart catheterization, but treating it appropriately. There are sets of medications that we can utilize for that. So that's one of the things that we're going to be doing in the meantime, is putting him on a medication called Renexa and then following up on symptoms. But we also have to realize that when it comes to chest pain, when it comes to chest discomfort, there's a whole lot of other potential etiologies, lot of potential causes for it. You can have things like reflux, you can have issues with the gallbladder, you can have issues with the chest wall cavity itself. This is known as costochondritis. So we do our due diligence in working them up and hoping that we can give them alleviation and some relieve their chest discomfort. So, you know, we're going to put them on therapies for it. There's also another procedure that we can do to definitively diagnose it, but I like to start them on the medications first and then see how they do. If they're still having issues, then take them back to the cardiac catheterization lab and do the official microvascular testing. Most of the patients that I see, you know, they do have coronary disease, and with this you want to look at potentially treating the risk factors for it. You know, high blood pressure. One of the things that that we see a lot is that a lot of these individuals also have high cholesterol or hyperlipidemia. Either they don't tolerate the statin medications because it can cause muscle aches, or they're on statin therapy, and they're on maybe the maximum therapy, and they still don't have, they're still not at goal. The best thing that we have now are called PSK9 inhibitors, things like Repatha, but there are also other ones like Leqvio. There are injections. Repatha is once every 2 weeks. Leqvio is about 3 times a year for the first year, and then twice a year. And they work really, really well in reducing it. The highest that I've ever seen it is 80, but the previous LDL prior to being on it was 200. So it dropped it by 120 points. Majority of the people that I see are usually between the 40s and 60s, so significantly reducing that LDL cholesterol. And there are some studies that are showing that if you can get that LDL cholesterol down to the 40s, that you can potentially have some plaque regression with it. So I saw a couple of patients who are actually on Repatha. One was on Leqvio, and they're just doing well. So a lot of times, if they're doing well, like, leave them alone. One of the quotes is that if it's not broken, don't try to fix anything. And right now, they're doing well with their lifestyle changes. They're doing well with their current medical therapies. Follow up with them. Make sure that nothing else is, that we're not missing anything else, but just let them be, let them enjoy the new year that's about to start. So those were a few of my interesting patients. Oh, so there was one that was pretty awesome. So he has history of diastolic dysfunction, but a form of heart failure where the heart is too stiff. And the reason this is important is because when he was first diagnosed, he was told he had heart failure. So we got him on all the right medications, lifestyle changes, and all the heart failure symptoms have resolved. So he comes to see me basically in tears because he believes that he's back in heart failure. So I asked him, yo, what's going on? And he said that when I was having heart failure in the beginning, one of the symptoms that I saw was leg swelling, ankle swelling, and shortness of breath. I'm not having any shortness of breath, but I'm starting to have the leg swelling again, and specifically ankle swelling, and it's making me very uncomfortable. So we looked at all of his medications, and I asked him, smiling, are any of your medication that you're on new? And he was like, yeah, I'm on amlodipine, the highest dose to help with my blood pressure. And boom, that was the reason. That was the reason for the high cholesterol, for the ankle swelling. One of the side effects of amlodipine, especially in the highest dose, is ankle swelling. So one of the ways that we can get by that, if we want to continue the medication, is to decrease it to 5 times twice a day, or if you're on 5 milligrams, 2.5 milligrams twice a day. If that doesn't work, then we may have to look at other etiologies, other medications to help with the blood pressure that doesn't cause ankle swelling. These medications, they work well, but you have to be very cognizant of the side effect profile with it. Some of it can cause ankle swelling, some of it can cause high potassium, some of it can cause low potassium. Biggest thing is, what's the right regimen for each individual, and if we can potentially get you on the medication, but also get you off of it with the lifestyle changes, with the weight loss, with the nutrition selection. If you can choose one of choose them all, but the biggest one is going to be your salt content, your salt intake. If you can control that, you can control or reduce the amount of medications that you're on for blood pressure, or potentially come off of all of them. So that was an interesting one that I saw. Again, I wrote it down just because I didn't want to forget. Yeah, they were all about the same, but those were the most interesting ones. And like I said, the most interesting patient that I saw was for atrial fibrillation, but I got so much more than AFib from him. He was just extremely happy despite all the issues that was going on in his life. Like, he had a lot of bad things going on, but was just happy to be alive and living life. So I just sat down with him longer than I was supposed to, but I enjoyed every aspect of it. He blessed me more than he could ever know, and I told him that. But grew up a pretty rough life, and now has seen just what it means to enjoy life. So whatever he's doing, he's enjoying it to his fullest. He goes hiking. If he throws a baseball, he was just enjoying every aspect of it. And I told him that he inspired me, that I need to start to have a better outlook, despite everything that's going on in my life, because my life and his life is his, but different ways of looking at it. He's a lot happier than most people are, despite most people probably having more than he has. With the minimum that he has, he's extremely ecstatic. So he helped me more just to understand that there's more to life than just obtaining items, obtaining wealth, obtaining fame. Life is life, and enjoy it, because you never know when your last breath is going to be. I think one of the things is I can worry about tomorrow, but I'm going to enjoy life today. And I just loved it. I loved it when he said that. So here I am out here taking a walk before I see my first patient. Dude inspired me, and my goal is to live life today, enjoy it, and see these patients, and then go have a great time with my kids and with my wife after I'm done. You guys take it easy. If you guys have any questions regarding the life of a cardiologist, life of a doctor, the life of a doctor, husband, son, the life of dual doctors, let me know in the comments. All right, peace.